I guess it's okay if the speakers want to sit in the bleachers for the duration. This is going to be on clinical benefits and comparative effectiveness of cancer surgery. And I told Tina and Patty I didn't really know much about this, and they told me that was a good thing. So I didn't get caught up in this. And I did read a little about it, and this should be a fascinating session. So the first speaker will be Richard Whelan from the Mount Sinai Health System, and he'll be talking about laparoscopic surgery. Dr. Whelan? And thank you for joining.
It's a great privilege to have the chance to attend this conference, and I always think these conferences where you get different specialties together, people that usually aren't together on a regular basis, and you see how similar the issues are in different areas, and I think we'll see the similar issues that were raised in the last session. Okay. So before 1990, there was only really one way to do. We're talk mostly about abdominal surgery, so there's only one way to do it, which was to make an incision and to go inside and directly deal with whatever you had to deal with, and it made sense. It was direct to the point, and it's also fairly quick. The downside, however, was that there was trauma to that related to the access to the abdomen that was possibly causing much of the pain that was experienced by patients afterwards. So you have your access trauma, and then you have your intra-abdominal trauma. Obviously, intra-abdominally, that trauma is unavoidable if you're going to remove the internal organ there that's coming out. You also have a systemic response, which is the sum result of the trauma to the abdominal wall plus the effects of the intra-abdominal portions of this. You had wound healing at multiple sites, and you had also a disruption of GI function that was the paralytic ileus, which is common to almost all abdominal operations. Now, in the early 1990s, the idea of video laparoscopy was introduced, and since in the last 20 years or so, it's really resulted in a paradigm shift, a sea change in terms of the way most abdominal operations are done, and this is true across specialty. The advantages of laparoscopy are that there is obviously less abdominal wall trauma, so the access trauma is considerably less. And this is tied closely to, we think, to the short-term outcome benefits, which is actually what has driven the entire field. And those benefits are less pain, and less need for pain medications, more rapid recovery in terms of ambulation, and in terms of bowel function as well, comes back, in an earlier tolerance of food, and a shorter length of stay, and also a faster return to work. Now, long-term wise, some of the less publicized advantages, which I think in the end will be the more important ones, are the fact that there's less abdominal wall adhesions between the viscera and the abdominal wall because you do not have a large incision. And so that translates, or should translate, into fewer bowel obstructions and fewer incisional hernias as well. And in fact, wound complications in general, both the short-term surgical site infections and their sequelae, as well as hernias and the adhesions, are not a small cost to the system. And so this is something that has not been proven well in any kind of randomized setting, but it's certainly the suspicion of proponents and surgeons worldwide. There's also physiologic benefits. I'm going to go into some of these, possible oncologic benefits, and there also have been shown to be cost benefits as well. So when I first was asked to give this, the question I thought I was being asked to address was the scientific underpinning of this, of laparoscopy. And the truth of it is, to be honest, at the start of this, there was none. There was very little. It was basically just the idea that we have instruments, that we have video laparoscopy as opposed to standard laparoscopy, which radically changed the ability of everyone in the room to see what was going on and to have assistants help you, and it changed everything. And so if it was possible to do, it was tried. And this is how this was brought out. It wasn't on the basis of any kind of evidence at all, except for a couple case reports, and then the idea that this was attractive to patients. There was no decision made by any entity as to when this would be rolled out. It just was rolled out. And the market pressures in all these things, whether they're real or perceived, are huge in terms of driving these new treatments and these new approaches. And it's, as in surgery, almost always the data and scientific evaluation comes after the introduction of the method. The perfect examples is cholecystectomy. This is the first big operation that was converted over, and this was based on some small case reports from France and then in the U.S., and there was a rash of weekend courses, hundreds of these courses in the first 7-8 months of 90 and 91, and then it went on for a few years, and everyone ran to do their first cases, and most of all the results were pretty good, but it was noted in the New York Times in New York State that the rate of common bile duct injuries was significantly higher in the laparoscopic cases in the first few years than it had been with the open methods. Nonetheless, these went on. It was patient-driven and also doctor-driven. And then some basic science studies were done, and most of the basic science studies, which looked at cytokines and short-term immune function, showed that there was some benefit to laparoscopy, but they're very short-lived benefits, as we'll see, and the actual clinical ramifications of these are unclear. And the laparoscopic methods became the gold standard overnight. And eventually, the common duct injury rate did come back down to the prior levels, but it took a while, and there was no way to get the horse back in the barn once this method had been unveiled. Now, laparoscopic colectomy, which happens to be my field, I'm a colon and rectal surgeon, is a very unique situation because when everyone rushed out to do these as well, they took their weekend courses, but a laparoscopic colectomy versus a gallbladder removal is an entirely different operation. It's much more difficult. You have to mobilize the bowel, you've got to devascularize the bowel, you've got to get the specimen out, and you have to do an anastomosis. So this is a much different than just taking a vestigial end organ and just clipping it and getting the one blood vessel in that. So most surgeons, when they tried this, they turned around and said, "Are you kidding? This is hard, and I'm not getting paid any more to do this, and it takes longer." So there was not a big internal rush to do this, and so that coupled with the fact that there were reports of port site tumors at the sites that were used to put in these laparoscopic ports, there was a number of anecdotal reports showing early tumors forming at those sites. So the concern was that maybe there was something about laparoscopy in general that led to this, and so it was blamed on the carbon dioxide, which is what you need to have. You can't do cell cultures without carbon dioxide, but that doesn't mean that that's the cause of it if you're in a CO2 environment, which is how we maintain our new peritoneum. But that was the view. And in fact, the minority view was in fact that probably related to surgical trauma, that using a new method with chopsticks, trying to get a tumor out, you haven't done many of these things, you might traumatize the tumor and break off cells, and they might find their way to the abdominal wounds. And also the final realization that in fact these do happen after open surgery, but they just don't happen that often. Now, what this did, though, is created an environment where the colorectal surgeons did not want to do this, and there was a pack of zealots, of which I was in that group, that believed that this was the way to go and it was the way forward. So they organized a randomized trials, and this was the first time this was really happening before the general acceptance and adoption of these methods. So the trials were set up, but that gave us a 3 to 7 year window to do some basic science studies to see if there was any kind of underpinning to this at all. And so this is, this is very unique and not to be repeated again in the surgical world. And surgeons are often, they're like cavemen. They're sort of, they see it and they go after it, they club it over the head, and they just tend not to ask the scientific questions up front. I hate to say that, but I think it is largely has been true on a worldwide basis, but we're trying to change that around. So what was the physiologic impact? What could we assess? We could assess immune function. We could assess plasma protein changes. How does it affect the protein composition, as it might affect physiology, cancer cell growth, or angiogenesis? And also the idea of, is the plasma in the postoperative state, does that in fact have any systemic effects on residual micrometastases that may be present at the time of surgery after the primary tumor has been removed? As far as immune function goes, we all know that not having immune function is important. If you have an immunosuppressed population of either transplant patients, HIV patients, or patients on steroids, they tend to have a higher complication rate than patients who are immunocompetent. And certainly patients that are allergic for whatever reason also have a higher rate of unresectability and higher complication rates as well. Transfusion, which causes a relative temporary immunosuppression, has also been associated in some pretty soft studies with worse results. The evidence for immune function after minimally invasive versus open surgery is present. It's a lot of animal studies, and there also is some human studies. And if you look at immunomodulators in terms of proteins in the blood, there definitely are less marked elevations in the laparoscopic cases. If you look at lymphocytes, you take them out and you then stimulate them ex vivo, you find that they're more readily stimulated after a laparoscopic operation, implying that they're more ready to work in vivo. The ratios of Th1 to Th2 CD4 positive lymphocytes also is in favor of the laparoscopy. Macrophage and poly and neutrophil studies also are a little bit more controversial, but again, seem to suggest some benefits. And I think the one example that is easiest to comprehend is the DTH data that's there. That's delayed type hypersensitivity. I'm just going to go over that with you briefly. If anyone who's gotten a PPD, if you've ever converted, many of us as doctors, I'm sure, have converted along the way, what you end up with is a wheel. You get injected to a antigen that you've been exposed to, maybe mumps, Candida, and then you wait a few days and you measure the size of the wheel, and that tells you that the body has seen this before, that there's a CD4 memory cell somewhere that recognizes this, and you get a response. The idea of using this as a marker of surgery, surgical immune function, was done by Keelit, and basically he did multiple tests, preoperatively, postoperatively, and you should get an increase in the response if you just give it multiple times because the patient's seen it again and again. But the idea was to see what happens after surgery. Now, we did this in my lab, and not my lab, but in my clinical unit. We basically compared control patients who had no surgery to the laparoscopic patients, which are the ones in the orange, and the open in the yellow. And what we did a panel of antigens. We pulled them together, and what we found is that whereas in the laparoscopic group we did not see a significant decrease in the size of the response, in the open group, in fact, we did, and that was measured out to postoperative day 3. So this suggested that there was some difference in cell-mediated immune function in terms of the different approaches. Now, if you put it all together, most of the differences that are there, though, are all, some of them are less than 36 hours in length, some of them are 24 hours, 3 days at the most. They're not long-term things, so the clinical significance of these is uncertain. However, we do have the clear-cut data now from multiple fields that show that the rate of wound complications and the overall rate of complications in general tends to be a bit smaller, significantly lower for the laparoscopic versus the open, and so this may be one of the reasons why that's the case, although it's not clear. Now, if you just look at non-immune cytokines, just the acute inflammatory response, again, you see the same thing. You see a definite advantage for the minimally invasive approach. However, the duration of these effects is very, very short-lived, and again, it suggests the open procedure is more stressful, but the clinical significance of this is unclear. We've looked at, in my lab, we've spent a lot of time looking at the longer duration changes. In fact, we found that there are proangiogenic blood composition changes that persist for up to a month postoperatively, and we've documented this with about 12 different proteins. And in fact, if you look at in vitro endothelial cell cultures, we can show that the preoperative plasma versus the postoperative plasma significantly increases the endothelial cell proliferation, migration, and invasion, which suggests that, in fact, that perhaps the micrometastases might be stimulated early postoperatively. And this, of interest, this is true on both laparoscopic and open, and it is no different between the two methods at all. They're identical in that way. And perhaps this is the more important change in terms of cancer growth. Now, there is a large literature out there that suggests that, and it goes back to Bernie Fisher, the University of Pittsburgh, and beyond that, to show that the surgical trauma is related to tumor growth, and that you look at, if you have a laparotomy in an animal versus anesthesia control, and you inject tumors subcutaneously, or you do it in the tail vein to look see if they have liver mets, you'll in fact find that they have a greater growth after they've had the surgical trauma. So there's something about the trauma of surgery that reduces the host's ability to fend off or to limit the tumor growth. Now, when the laparoscopic era came along, many investigators began to look and see, is laparoscopy different than open surgery in that regard? And we did a study looking at laparoscopic cecectomy, which is a minor resection, but it is some procedure in a mouse, and you could do this laparoscopically versus open. And we injected tumor cells into the tail veins, and it's a model that will give you surface mets on the lung itself 14 days later. And what we showed was that there was a stepwise increase from the anesthesia control on the far left to the laparoscopic assisted in the middle to the open in the far right. So this suggested that the access trauma alone was enough to influence tumor growth rates postoperatively. Now, we shifted then to human studies and looked to see if the blood plasma changes that occurred as a result of surgery impacted at all in vitro tumor cell growth of a human colon cancer cell line. And so we did this with a variety of patients. We looked at both cancer and benign cases because we firmly believe and have since shown that this is not related to the indication for surgery, but it's related to the amount of surgical trauma in terms of the effects that we've been able to demonstrate. So we looked at a number of different cases, both colon and also gastric bypass. And what this shows is the results of in vitro tumor cell cultures The BRDU incorporation, which is on the y-axis, and the x-axis is each blue line represents a patient. The top of the blue line is the extent of tumor cell proliferation in vitro with the preoperative blood, and each red dot is the postoperative day 1 tumor proliferation results from a separate culture. You can see that the majority of the patients demonstrated accelerated tumor growth 1 day after their surgery, after open surgery. But if you look at laparoscopic results, you see, in fact, it's the other way around. It's about 20% are elevated, but the majority of them, their proliferation rates stayed as where they were or went even lower than they had been. This effect did not last past postoperative day 1. On postoperative day 3, the results were back to normal. This came out coincident with the first single-center randomized trial for colon cancer, which was done by Antonio Lacy in Barcelona. And in fact, he showed in a study of 255 patients or so that, in fact, it looked like there was a survival benefit for the laparoscopic group, which was great, was huge news at the time, and piqued everyone's interest. However, because of the concerns of port-site tumors, and again, the majority of people were thinking this was not a good thing, the randomized trials were done, and they were all done as non-inferiority trials, just trying to show that the laparoscopic method was not any worse than the open method. And so there's been a number of these, and these are the ones that have come to fruition. Several thousand patients, around 3,500 or so, have been randomized in both European and American studies. The American was the first. And in fact, if you look at lymph node harvest in terms of can we do the same kind of cancer resection, the results are similar. If we look at the 3-year and 5-year disease-free survival and overall survival from these various trials, it also shows no difference at all between the groups. Now, I'm going to shift. So the end is the cancer results seem to be the same. The short-term results in terms of recovery are in favor of laparoscopy. So because of that alone, it's driven the whole thing. There are those of us who believe there are some of the benefits I've showed you, but there's nothing that's been shown clinically that would verify that. So what about the other areas where minimally invasive methods have been applied? Morbid obesity surgery is a good example, though it's not a cancer. And with this, we've seen the same kind of benefits. Lower wound infections, and in fact, they see improved pulmonary function, but that could also be related to the wound loss, the weight loss. And overall complication rates have also been shown to be lower. But what's critical about this is that the volume of cases done in this field increased by 7-8-fold because this was now a more viable, attractive option to patients. So it had a huge impact on the number of cases done. And the interesting thing is that one of the things that's come out of this is that the mortality of these procedures, which open was 1.9 to 4% mortality, perioperative within a month mortality with open procedures is now down to 0.1, 0.3%. And this is thought to be the fact that obese patients have a chronic inflammatory state that's the low-grade inflammation. The adipocytes produce cytokines that can influence immune function. And the fact is that somehow the minimally invasive approach does not stir it up as much as the open. And so there's a real benefit in terms of these surgeries, to the point now where if they can't do it laparoscopically, many minimally invasive surgeons will just not do the operation, which I'm not sure I agree with that. But the point is, this is an example of how the minimally invasive method has made such a big difference. Now, as far as GYN goes, for laparoscopic versus open, there's good evidence to show that it results in a shorter length of stay, and the complication rates are lower in the laparoscopic group. And we've seen an increase in the utilization rates in this specialty as well. Now, it's just to touch on the economics, I think it's important. The basic economics of laparoscopy is it's very technology-laden, so it's more expensive up front. The actual procedure cost is high, but if you can get the patient out of the hospital sooner, you save money on the backside. And also, it's become clear that if you look at 60 days or 90 days out in terms of the complications that occur in the wound infections, dehiscences, and the need for therapy there, the costs are significantly lower if you can do it minimally invasively. And so because of that, there are cost savings when minimally invasive methods are used, despite the very high cost of the operation itself and getting those equipments on board. If you look at just a few different areas, ventral hernia repair, it's been shown in good studies that the laparoscopic is cheaper. Colectomy, 90-day costs 1.26 times more expensive for the open. As far as hepatectomy, pancreatic resection, savings again for laparoscopy, and gastric bypass as well. So there seems to be a cost savings with this, as well as benefits for the patient short-term wise as well. Now, as 20 years later, there's a whole new group of splinter methods that come off the basic laparoscopic method that's there, and they're listed here. I'm going to talk briefly about robotics, which is the one that has had to gain the most traction in the years that have followed the introduction of these methods. And this just shows one of the robots. I'm not sure which generation this is, but it's one of them. This just shows the idea of how it's done. The surgeon is at a console away from the patient. There's a bedside surgeon. The robot is docked to the patient, and then the operation is done. In some operations, there's a one-quadrant operation. This can be done with just the robot alone, but in other cases where you need to work in multiple quadrants, it can be done in combination with laparoscopy, standard, and the robot, or moving the robot around and using it for the whole case. Now, the advantages are you have 3D images versus the 2D image we get with laparoscopy. The wrists for the robotic wrist can move in multiple ways that our wrists can't do, so there's greater mobility there. The camera position is fixed by the robot. There's a fourth arm that allows you to control your own retraction, so you have more control over the whole operation. And the deep pelvis, especially if you're having to suture, there are clear advantages to the robot in that way. However, most of the operations that have been done have been designed so we don't have to do any intraoperative suturing, and so for colon operations, there's not really a need for that. The other thing is that robotics is a little bit easier to learn if you have not done much laparoscopy to start with. Now, the disadvantages are the cost. The outlay for the robot is quite high. There's a yearly maintenance cost per robot. You need to have devoted tools for that, stapling devices, for tissue division devices, and so there's a cost to those. There's also disposable basic laparoscopic tools that after 10, 12 uses have to be replaced. There's also the loss of haptic feedback. You don't have any sensation back of how hard am I grasping something. Laparoscopically, we can tell how hard we're grasping things. You have a sense of this, whereas with the robot, you don't. So there's a loss of that. And the OR time in most series is longer, and the cost per case is higher than for the equivalent laparoscopic procedure. And also, if you do the operation alone, as far as training, it becomes a whole different issue in terms of having someone trained in this. There's ways to do this. They have separate robots right next to them for training consoles, but it's not so easy to do. And once a resident has learned how to do it on the robot, he's going to have a robot where he goes in order to do this as he moves on. Now, the highest penetration of this has been in urology, and this is where there was not much going on in terms of straight laparoscopy. And the prostate is an ideal operation because it's one quadrant and it does involve suturing. So this is something where this has really taken off and was the main operation for many years. The people that have experience with the straight laparoscopic approach are not as prone to use this. But the results right now, in terms of in the US, about 85% of prostatectomies are done with a robotic approach, 14% open, 1% lap. And the short-term results are better in the robotic versus open. Functional results are the same or possibly better, but that's controversial. Long-term oncologic results look similar. Utilization rates of the robot have plateaued. And as we've heard, there's multiple other ways to deal with prostate cancer, and some of them don't need to be dealt with at all. So the point is that this has kind of limited the growth in that field. If we look at rectal cancer, which is another whole indication, we find that, in fact, the place where it's said to be useful is in the deep pelvis, where we're doing a low anterior section, a sphincter-saving procedure, and the idea is it is useful down that way. And when you compare that to an open operation, there's clear advantages. However, if you compare it to a laparoscopic procedure, in fact, the benefits have not been demonstrated thus far. A recent randomized trial, a limited number of patients, let's say 350 to 400 patients, been done, and in fact, the results were just reported on in Boston a few months ago, and in fact, it showed no difference in the quality of resection of laparoscopic versus open, no differences in short-term outcome or length of stay. However, there was a trend towards lower conversion rate with the robotic in the obese males, but that was the only difference, and it wasn't even a significant difference found. So and the other thing that's become clear is that if you use the robot for all of your cases, then it works, you get better at it, and your utilization time comes down, and you become more proficient at it, and the length of operations come down. But the point is, most of the operations in our field are operations where there's no indication for it at all. In gynecology, the operations are longer. This is a one study. There's a 7-hour shorter length of stay for robotics, which is not that long, but that's what they've reported. The costs are higher. Complication rate a bit higher for the robotic. And so the conclusion of this study was it advised limiting the use of this to the trial setting. Summary, laparoscopic methods are now the gold standard for a good number of operations, and I think with data to back that up in terms of both cost data and also in terms of outcomes. The scientific evidence is there. We're not sure of the significance of some of it, but there does seem to be benefits we can document in terms of basic science things, although, again, not sure how important they are. The splinter methods, again, robotic is the main one. You know, we don't have enough data for this yet. The results so far are equivalent. The costs are higher, and I believe that unless the clinical results are shown to be superior in a meaningful way, that it's going to be hard to justify the outlay of the purchasing price for the robot and also the growth of this. However, centers that have these robots now feel that they have to use them as well, so there is a push on the institutional level for the use of these robots. Finally, the final summary slide, the minimally invasive approach, less abdominal wall trauma. Inflammatory response, immunosuppression is less. less stimulation of cancer growth, at least in the animal studies and early postoperative data from humans. Long-term oncologic results are the same. The short-term results we've gone over. Thank you for your attention.